Welcome everyone to our webinar, which is, sorry, get the title. Did the rural health infrastructure break down during the pandemic? Evidence from the 2020 meatpacking plant COVID-19 outbreaks. My name is Maria Marshall. I am the director of the North Central Regional Center for Rural Development. We welcome you on our webinar. Our presenter will be Dr. Thomas Krumel, Assistant Professor in the Department of Agribusiness and Applied Economics at North Dakota State University. Thomas is an applied economist whose research focuses on rural health, labor, and regional development. His recent work examines how industry shocks such as COVID-19 outbreaks and meatpacking shape community health outcomes and strain rural infrastructure. So, Thomas, I am very happy that you're going to be presenting your webinar. Thomas also received some funding from NCRCRD to do some of this work, periphery, I guess, to this work. So we're looking forward to hearing the results of your research. And with that, Thomas, I will pass it on to you.
Thomas Krumel, North Dakota State University, as Maria said, some of this research was graciously funded by the center. So the support that I received made this possible. So excited to share the results from that supported research. So this research line kind of started when I began with the USDA. So I was graduating from the University of Connecticut in February of 2020. My dissertation was on some community development aspects of the meatpacking industry. I started in Kansas City with the RS 3 weeks before the pandemic started, and meatpacking became a significant concern from the supply chain and the health management issue fairly quickly on in the pandemic. So I was tasked with transitioning my industry knowledge at the community level to kind of understanding how the pandemic developed in the specific industry, which led me to kind of asking the question, why meatpacking, why rural? So meatpacking is a rural-dominated manufacturing industry with heavy consolidation, both in terms of the number of producers that exist in the market, as we are once again revisiting fairly recently, and more importantly for the impacts on the COVID side of things, it's a labor intense and dense manufacturing process. So quickly after the pandemic had become national in scope, we started to see that meatpacking plants, along with jails, became major epicenters, and in much of the especially Midwest, North Central region, where we were insulated from early pandemic impacts, these plants became major epicenters in March, April, and May. And at least in terms of the academic research that came out exploring the early impacts of the pandemic in the meatpacking industry and the subsequent impacts on the communities that hosted the plants, is that there was a massive COVID-related mortality that was generated based on the outbreaks. Some of that earlier research was implying that the excess mortality that they were observing in their analyses were related directly to the COVID outbreaks. And this webinar is kind of combining the results from two papers that I subsequently published, and the collective research that I did with two of my grad students demonstrated that, much like the narrative that was going on when these outbreaks were first occurring, is in terms of the overall cases, they were extremely severe. And some of my earlier work that was published through the USDA argued that maybe the case outbreak was more severe than people anticipated, and people were kind of suggesting was occurring. So after I moved into an academic position with NDSU from my initial placement with the USDA, I tried to expand some of this work, and I'll discuss some of the cool data that me and a grad student got access to. But we were able to get information on individual death certificates for Minnesota and South Dakota. And to remind you all of the situation that was happening in Minnesota, you have Worthington, which is located in Nobles County, which was one of the largest outbreaks in a rural context. And in South Dakota, the Sioux Falls plant also was one of the more the outbreaks that made national media attention in Minnehaha County, which is not directly rural, but did illustrate that there was kind of a differential impact that communities had to deal with in terms of meatpacking outbreaks. So the research that me and my NDSU grad student did, looking at the individual death certificates, suggested that the worker deaths were lower than one might have expected, given the media attention that the industry received. And we kind of looked into the data a little bit more, trying to see if there were some other things that we could tease out to get a journal article out of our analysis. And one thing that we noticed fairly quickly was, even though the worker death toll was smaller than you might have expected given the media attention, we noticed that the excess mortality that existed in the rural communities was fairly high. And surprisingly to us at first, it was largely unrelated to COVID-19. So we started to try to digest the data that we were analyzing, and I think we came up with a fairly compelling story of what ultimately happened in terms of the rural community experience, more broadly, using the meatpacking industry as our initial gateway into exploring that. So here's a chart from the first paper that we published. The blue part of the line is rural counties that have a manufacturing plant with more than 20% of their employment in a single category manufacturing industry. And you can see that it's a fairly low number of counties that are this dependent upon a single industry. But the one outlier that you see pop up is that there are 49 counties in the United States that have 20% or more of their employment in animal slaughtering and processing, the NACE code distinction for meatpacking. There are another 7 counties that are metro. I mentioned Minnehaha. I don't believe that is one that is dependent on meatpacking, but South Sioux City, Nebraska, so Dakota County would be a example of a metro county that is dependent upon meatpacking employment. And Nobles County that I previously mentioned in Minnesota would be an example of a rural county that has their employment base dependent upon meatpacking. So in terms of the rural context, meatpacking is a significant economic engine for a number of rural counties in the United States, disproportionately so compared to other manufacturing industries. So in terms of the overall employment, meatpacking is an industry unlike any other that we have in the United States. And that also leads to some things that made COVID-19 spread possible in meatpacking plants relative to other manufacturing types. So what this talk broadly covers is a brief reminder of the working conditions that led to COVID-19 spread amongst the working population in those plants. Then we dive into our analysis of cases and mortality dynamics. The death certificate data that we had access to. So for South Dakota, we had to work through the Department of Health and aggregate the data at cells that would not identify individual people. But Minnesota has their death certificate data publicly available. You have to purchase it, but it is individual level day. So we are able to see the specific occupation, demographic information, and importantly, for Minnesota data, because I've worked with this kind of data in other states as well, Connecticut and Massachusetts. Unlike the other data sets, we had the residential address of the individual. So we did some cool spatial analyses over the deaths data that we had access to, which kind of led us to have an interpretation of the overall effect that I think provides a more nuanced in understanding of the dynamics that were occurring during this time frame. And then we'll talk through the event study. That's the technique that we use visually to demonstrate the timing of the excess mortality that we observed, or when I'm calling the system breaking. And then ultimately the policy lessons that come out of this line of research for rural resilience moving forward. So some reminders of what was going on in early 2020 for individuals who maybe were not following this as closely, or if you were at the time, maybe it was not the core memory that has stuck with you. So plants were national spread accelerators. I know I was stuck in my apartment in Kansas City, which I had moved into this point like 2 months before the pandemic broke out. Didn't really know anyone, so I had MSNBC on constantly while I was doing my work for home stuff. And on a daily basis, you would hear about an outbreak happening at a new plant. Some early papers attempted to try to understand how these plant outbreaks impacted the overall health outcomes of individuals living in the United States. And there was a pretty wide disparity in the attribution of death, specifically COVID-19 death, with these studies because of the differences in the methods that were being used. So we were all trying to do the best that we could to understand a quickly developing situation that none of us had ever experienced before, utilizing data sets that we did not have expertise in. And the data that we were working with was imperfect, which led people to come up with early estimates of the impacts, which were valuable at the time. And some of these analyses have held up relatively well. But ultimately, there were assumptions that needed to be made in terms of the modeling, and the results ended up differing. The cases were fairly consistent across the literature, but the overall attribution of deaths was fairly wide depending upon the method that the researcher was using. And utilizing death certificates to evaluate the actual end outcome, I think me and my grad student have landed on a fairly clear understanding of how retrospectively the impact of the pandemic on these rural communities occurred. But while we were in the moment, there was a bit of a difference in the overall estimates. My point is, to a certain extent, that kind of caused us to miss the most important aspect of what was going on, which a lot of the discussion at the time was revolving around the plants themselves. which deserved significant attention, but from my perspective as someone who was evaluating both during and post, a lot less attention was given to the rural health systems and how they were able to respond to this at the time, which led me to ask the question from the second paper that I'll be presenting some results from today, which is, did the system fail and not just the plants? And the argument that I'm making is that we had a system-wide failure, which led to higher levels of excess mortality. And it largely occurred because of the outbreaks that happened at the plants. But because of the attention that the plants received, I don't know that we necessarily focused as much on the lack of available infrastructure that rural communities had to manage these massive outbreaks. So section one, reminder of the working conditions and the overall spread. This was the work that I was doing at the USDA during the pandemic. We did some analysis on BLS data. The ONET has work characteristics, which included things like physical proximity of the workers. And me and my grad student at the time did analysis on every single one of these ONET categories based on industry. And we found that physical proximity of the workers in the meatpacking industry were 3 times above the standard deviation for all other manufacturing that was included in our sample. And for those of us who have maybe been a few years since we took our college stats course, what 3 standard deviations means in a broader interpretation is meatpacking is very, very different than all other manufacturing that we considered. The typical worker was an arm's length away from their colleague, and we had other individuals in the plants who were even closer. And this chart just shows that on the left-hand side, those are less than the average. On the right-hand side, those are more than the average. And the work characteristic that was most different from a positive perspective, comparing meatpacking to other manufacturing, was the physical proximity of the workers. You see other things that would have also jived with the overall meatpacking process. So repetitive motions, time spent standing, time using tools, hot, cold temperatures, work with group, unpleasant people, pace of equipment. These are all things that we are well aware of existing in the meatpacking industry broadly. And of those things, the thing that was most different between meatpacking and other manufacturing was the physical proximity of the workers. So why does physical proximity matter? I think we all are fairly aware at this point, given how the pandemic moved forward. But early plants prior to the pandemic had no barrier, no spacing, rapid line speed. So the physical proximity of the worker created a spatial infection cluster inside the plants, matching documented internal transmission geometry. And it explains why cases spiked with the plant curve. So this is what a meatpacking line looked prior to the start of the pandemic. You had workers elbow to elbow. This is a graphic that I took from a New York Times piece to illustrate. And if you look at the overall cases, this is relative to the other manufacturing dependent counties. So the logic behind this research was meatpacking is going to be most comparable to other counties that were equally dependent upon other manufacturing industries as a way to compare. And compared to other manufacturing industries that did not have the same level of physical proximity of the workers during the outbreak period in early April, we see and into mid and late April, we see the meatpacking dependent counties had 12 times the amount of COVID-19 cases, moving average, relative to the other manufacturing industries in our sample. And the other interesting pattern that you'll notice is after we hit the peak, we had some plant shutdowns. And then around May, we started implementing improvements into the overall working conditions for people in the plants. And you see a precipitous drop in the number of cases relative to other manufacturing, which ended up being effectively identical starting in July and maintaining for the remainder of the year. And this is what a meat packing plant looks like after the adjustments are made. Was we had plexiglass dividers between workers, we had PPE being utilized, we have more space between individuals. So what the previous figure suggests is that the initial conditions created a situation where spread occurred. And then the meatpacking plants adopted their behavior, started protecting the workers from getting sick, and it seems to have worked. What we started off by exploring in our second paper, the one that I started when I got to NDSU, was initially we got the death certificate data, which contains the occupation of the individual, and we wanted to see how many meatpacking workers died from COVID-19 during this time frame, which was kind of spin-off work that I did looking at Massachusetts and Connecticut, trying to see how minority workers were employed in essential positions, frontline positions, and that helped to explain some of the mortality gap across the racial and ethnic groups. So we started off this analysis with the thought of analyzing whether meatpacking fell into this bucket as well. And what we found pretty quickly is that the number of meatpacking workers who had death certificates in our population was significantly smaller than we initially had thought. So looking at the data from March to July 2020, again, this is for Minnesota and South Dakota, two states that were impacted significantly from the COVID-19 outbreaks. They had an estimated 21,000 individuals working in the industry, and we found evidence of 8 individuals dying from COVID-19, or 0.04%. That's not to say that the number of meatpacking workers who died was not large. Relative to other working age COVID deaths in our sample, it was 10%, which for a single industry to be that large is fairly significant. But the main pattern that we started to determine, and this kind of came out in the previous paper as well, is that meatpacking workers tended to be younger and healthier on average. So we wouldn't necessarily have expected those individuals to be the ones to die from COVID-19. And that's what the data suggested. Looking at the table, the temporal pattern, the time period that we see, the majority of the COVID-19 meatpacking worker deaths that we observed occurred in May, when the outbreaks were lagged from their peaks. So remember, 2 to 3 week gap between catching COVID-19 early on in the pandemic and passing away from COVID-19. So these individuals likely got infected in April, died in May. So when the outbreaks were at their peak, that's when individuals were having unfortunate health outcomes. But you see, starting in July, and this continues all the way through September, there wasn't another meatpacking death within our sample. So from March to July, 10% of all the working age deaths that we observed in our sample occurred from meatpacking workers, but the number of meatpacking workers who ended up dying relative to the number of meatpacking workers in the population was relatively small. So that was somewhat surprising to us and led us to ask some supplemental questions. So I kind of already talked through some of this, but why so few deaths in the workers? Relatively young, healthy population working in meatpacking plants. We talked about how they adopted mitigation measures by May. This was consistent in terms of the timing with the plant level adaptation evidence, and there was a serology study done in Nobles County specifically, which suggested that there was a high infection rate that occurred and a low death number that occurred. And thinking back to our overall data analysis for Nobles County specifically, there were not a whole lot of deaths that occurred during this time period when the outbreak was happening at the Worthington plant, not just in terms of COVID deaths, but deaths in general were not significantly out of line with what we've seen previously. So the argument that we make in this paper is the real crisis that was observed was in terms of the overall excess mortality, not necessarily the deaths that occurred from COVID-19. And to paint the picture for you all again, you had the outbreaks that occurred at the meatpacking plants, and we were still fairly early on into the pandemic where we didn't really know how serious the virus was going to end up being. So we were having a lot of hospitalization that was occurring from individuals who got sick with the virus, taking up a number of the beds that existed within the hospital. You had places like New York City having to implement supplemental uh, uh, hospital space outside of their normal infrastructure. And places like New York City have significantly more beds than a county like Nobles County in Minnesota. So if you have an outbreak occurring at a 2,000 person manufacturing plant and they're taking up all of the hospital bed space, that leaves less available treatment options for other individuals who get sick for things other than COVID-19. And that's kind of the direction that we moved into with the research question that we asked in this paper. So as I mentioned, we had the residential address of everyone who died in our Minnesota data set. And we created a spatial buffer 15 miles around every large plant that we identified in the data set. We were able to identify who died from COVID-19 and who died for causes other than COVID-19. And we compared the deaths that we observed in 2020 to the prior year. And the distance buffer that we utilized was following previous research, but we buried the buffer and found that our results were fairly robust. So this is the chart that shows the geolocated deaths. So we have the residential address of everyone who died in our sample. We used spatial tools to figure out where they were located on a map. And then we drew a circle around our meatpacking plants and first looked at everyone who lived 15 miles or less away from a meatpacking plant. And an interesting number popped up to us that of the excess deaths that we observed, 65.2% of them were not explained by COVID-19. So we've got metro counties like Minnehaha, we have Stearns County, St. Cloud, Minnesota included in the sample. We were more concerned about the overall rural experience than the metro. So we decided to drop all of the metro deaths that we observed and looking just at rural meatpacking deaths, rural deaths proximate to a meatpacking plant, we found a similar percentage as we found including the metro areas. So it seems like the rural experience was fairly similar to the meatpacking experience broadly. The next thing that we examined was, okay, what was the rural experience if you were farther away from a meatpacking plant? The rural communities farther away from a meatpacking plant still had excess mortality in 2020. However, the excess mortality was mostly COVID-19. So if I was close to a large meatpacking plant and I died in excess of the prior year numbers, it was likely that my death was not attributed to COVID-19 based on the death certificates. But if I lived more than 15 miles away and I was one of the individuals who died above the number in the previous year, it looked like I probably died from COVID-19. So the experience that a meatpacking proximate community had relative to a non-meatpacking community in rural America in terms of the overall health impact appears to be fairly different looking at the death certificates of the individuals. So to summarize this, inside the 15-mile radius, nearly two-thirds of excess mortality was not COVID-19. And in the paper, we make arguments that this was fairly strong evidence of the rural health system broadly being overwhelmed. And we did some additional work to try to better tease this out, which I'll talk through some of that later on in this webinar. But before we get there, another thing that we examined, because I said this was follow-up work to some stuff I did in Connecticut and Massachusetts, looking at frontline employment more broadly. And that research line, we examined the ethnic and racial impact of COVID-19, looking at the types of jobs that individuals were working. And we found a large ethnic and racial gap in the amount of people who were working frontline positions and unfortunately passed away. So we did a similar type of analysis in this paper where we looked at the share of minorities who died in 2019, which was 3.2%. This is in proximate to a large meatpacking plant. In 2020, that number rose in terms of excess deaths to 26.2%. And of those individuals, 17.5% of them were non-COVID-19, which we interpret this as the minority communities who are close to the plants were the ones who internalized a lot of the system breakdown. So there was significantly more ethnic and racial minorities who died above their prior year number during COVID-19 and passed away for reasons other than COVID-19 illnesses. So one of we actually got really lucky with this paper in the second journal that we submitted it to. We got a really helpful referee who suggested to us that we have an interesting empirical story here. The statistical analysis that we're doing is impactful, but we're missing the key economic interpretation of what's going on in this situation more broadly. And the referee suggested that we incorporate some economic theory to help explain what's going on here, which led us to kind of look at the overall health system, what we term in the paper production function, but effectively how the rural hospitals provide their care to patients based on the number of workers that they have available and the other inputs that they have, machinery and stuff. And one of the things that stuck out to us fairly quickly was that rural communities had a major workforce shortage in terms of health providers during this time. And looking at some of the pre-existing data, we found that if you account for the population, the staffing was similar across rural and metro, but because you're accounting for population, the absolute or the level amount of workers is drastically lower in a rural county. So a rural hospital with 40 employees cannot respond to outbreaks in the exact same way that a metro county with 1,000 employees can. So we make the argument that there was not a whole lot of substitutability that was able to be done in terms of the workers at the hospitals most affected. And to think about this in more simplistic terms on why elasticity, which is an economic term, is something that we would care about here. You can think about hospitals as producing health outcomes, with labor and equipment being the things that they use to treat illnesses. And you can think of a substitution elasticity in plain English as the ability for a hospital to reassign or reallocate the inputs. What the rural hospitals at this time were experiencing were fewer workers, and you had metro hospitals utilizing travel nursing at a far higher rate. They also had a lot more money that they could use to pay the higher salary that travel nurses were commanding during this time, whereas rural hospitals function on tighter margins. They were less able to recruit additional workers to help them triage the situation. They have fewer specialists. They have some fixed cost constraints, and they have heavy triage burdens. So ultimately, the argument that we make in this paper is that when cases surged, again, using meatpacking as our illustrative example, but our analysis extended far beyond just the meatpacking communities, rural hospitals were less able to substitute inputs. And as a result, we infer that non-COVID care was delayed or rationed. And to a certain extent, you also had some concerns from individuals who maybe had illnesses other than COVID during this time. So if I was concerned that COVID, going to a hospital, interacting with people who have COVID was going to potentially make my outcome worse, I might be not wanting to check myself into a hospital, even if I needed to. And the argument that we make is that much of the excess mortality that we're observing, specifically in the rural communities in our sample in Minnesota and South Dakota, were likely this non-COVID care that was delayed or rationed. So the more formal analysis that we do to kind of tease out this temporal or time period is what is known as an event study. I'm not going to throw any equations or anything technical up at you. It's a fairly informative picture that we can walk through together. So the way that we developed this type of analysis is we first had to define what our event would be. And the way that we defined our event in this paper was the first day that a county reaches COVID cases in the double digits. And then we did a subtraction, which got us the excess deaths before and after the event. So we took the number of people on the day that we had the event occur who died in 2020 minus that from 2019, and then we did that for the subsequent, I believe, 5 weeks. And we also did it for the 5 weeks beforehand. And importantly, for our statistical inference, we found no evidence of excess mortality happening before the event that we analyzed. And also importantly to our story, we found that the excess deaths spiked exactly the same time that cases were peaking. And after the cases started to level off, we found that the excess mortality also started to dissipate. And the reason why that result is informative is, remember that if this is misrepresented COVID-19 deaths, at this time we had a 2 to 3 week lag in someone getting sick and then ultimately passing away. So if what we are observing in this analysis is unreported COVID-19 deaths, what we would expect to see is that during the time period that the cases were surging, 2 to 3 weeks after that time period is when we should observe the excess mortality. That's not what we see in the analysis that we did. We see it happening at exactly the same time, suggesting that it was the lack of available infrastructure that was leading to these excess deaths and not the misreported COVID-19 deaths. So to justify the definition of our event, here is tracking the 1 week moving average in daily new cases for the 5 weeks before the event and then the 5 weeks after the event. And you'll see that there was a small upward trend that happened leading up to the first day that we observed double digits COVID-19 cases. And then at the point that we hit double digit COVID-19 cases, we have this inflection point where the number of cases kind of explode. And this peaks moving into week 2 and week 3. And then moving into week 4 and week 5, we see a leveling off. Not necessarily that we don't have COVID in the community anymore, but it's not at the peak level. So when we move to the event study, we're going to see if the COVID cases, the illustrative example of the meatpacking community. So if we have an outbreak at the plant and we have the number of beds being taken up by the workers at the plant, that's peaking in week 2 and week 3. Those individuals, if they are going to have a super negative outcome from COVID-19, we'd expect that to happen at about week 4 or week 5. But what we observe is that the excess mortality is significant in week 2 and week 3, which matches the period of the cases. So to give you the picture, on the horizontal axis, we have the days relative to the event, like we do in the previous picture, but on the vertical axis, we have excess non-COVID-19 mortality. And the overall pattern that you're going to see is flat before the event. For the academics in the room, this is the suggestion of no pre-trends. And then we see a sharp increase after the event with a leveling off, and the only 2 time periods being significant are week 2 and week 3. And this is when the cases surged, and the argument, our interpretation of the analysis is that this is when the rural health system failed. So here's our picture. Time 0 is the event when it happened. That's week 0. Anything that happened prior to is the time period before we hit our double-digit cases in the county. And you see the red line is effectively 0 and not statistically significant. So prior to the event happening, we have no evidence of excess mortality. Then we hit week 0, week 1, we see an upward trend, but the confidence interval is not above the red line, so it is not significant. And then we hit week 2, and the confidence interval is now above the red line. Week 3, the confidence interval is above the red line and is continuing to trend upwardly. And then by the time we hit week 4 and week 5, the leveling off period that we saw in the COVID cases chart, we start to see a leveling off in the excess mortality that is no longer statistically significant. So in this instance, the suggestive evidence from this chart is that the excess mortality occurred exactly the same time period that the COVID-19 cases were spiking. And the argument that we make in the paper is this is likely because the rural health infrastructure was unable to handle the case outbreak, had to start triaging care, and unfortunately individuals with illnesses other than COVID-19 likely were the individuals who were negatively impacted by this. So our interpretation of implications for rural development moving forward, I think we're all aware that the rural health infrastructure is sparse and has been getting more and more less defined as we have consolidation and rural hospitals closing down. And there are practical business reasons for that. But when we hit something like a pandemic with um, a disease that spreads easily, especially in in proximity in a meat packing plant, as an example, that's going to have pretty significant impacts on our overall rural health structure, which is going to have pretty important implications for rural development broadly. So, our main findings were outbreaks originated at plants, but overwhelmed rural hospitals. The meatpacking workers' deaths were relatively low, in spite of the fact that we found little evidence that the workers themselves were the ones who were dying in the excess mortality. We found evidence of fairly high excess mortality that happened around this time period, and it was also highly racialized for ethnic minorities and um, racial and ethnic groups. And we go into a lot more detail in the paper, but the rural health system in a lot of these communities lacked surge capacity, staffing flexibility, equipment, and testing and tracing infrastructure. And one of the narratives and the important stories that got lost when we were pointing out how bad the outbreaks were in the meatpacking plants themselves, which they were really bad in the meatpacking plants themselves, was also just how rural America in general dealt with the pandemic in a different way than other parts of the country, irregardless of whether it was from the meatpacking plants or when the virus became endemic in the community naturally. All these things were issues that these communities had to struggle with, and metro communities also had similar issues as well, but the rural communities largely had less resources to um, alleviate the problems that they were seeing compared to places like Chicago or New York City or Los Angeles. So our thoughts on policy lessons that we could potentially take out of this moving forward from the pandemic situation in terms of how do we prepare rural communities to be more well aligned for whatever happens next when we do need to have a viable infrastructure in place. Some things that we could be working to enhance are strengthening rural hospital surge capacity, investing in flexible labor, not just relying on travel nurses who, given the demand for their services during this time, became fairly expensive to have come to your community, but also investing in preemptive cross training. So if something like this ever happens again in the future, we're better prepared to be able to handle the difficulties that arise because people can jump between different roles to service the individuals who are coming in a little better. Have a better health data system built in where we are able to track things effectively and I guess accurately as soon as possible. And this is a once every 100-year pandemic, knock on wood, that we had to deal with. I think we did a great job in getting the data that we needed as quickly as possible to individuals who could analyze the data and try to see patterns. But making sure that data is readily available as soon as possible so that we can preemptively tackle some of these things, have some employer public health coordination come in, and maybe this is somewhat complicated from the private firm's perspective, but if we're having those relationships developed before something negative happens, it's a lot easier to address the problems after they occur rather than trying to build those relationships and fix a national issue all at the same time. And one thing, given how important meatpacking as an industry is to the rural communities that house the plants, maybe treating it as critical infrastructure regions, not just for we need to continue to have the food system not impacted by the pandemic, but also recognizing just how important these plants are to the communities that house them, and finding ways to enhance and better understand how the industry impacts these communities preemptively might be the type of thing that can help us to not have another repeat of this in the future. So my closing argument is the outbreaks that happened at the plants were the issue inside the plants. And I don't want to underscore just how important that is. The thing that sticks out to me, though, is that the problem was not just the plants. And the discussion that happened around this time was largely around the individual plants and did not have the more holistic evaluation of how the community as a whole was internalizing this. And we knew even before COVID-19 that the rural health system was already stretched thin on a per capita basis or a population weighted basis. We probably had sufficient health care given normal conditions. But what COVID-19 did was it exposed the fault lines of the lacking infrastructure that we had, and it's going to take something like a COVID-19 to break the system. But I guess I'm arguing that preemptively, maybe what we want to do is ensure that the system is robust before we have something like this happen again, so that when in the future we have another pandemic or some kind of other natural disaster that we have to deal with in rural America, we're not lagging behind and trying to fix the problem in the moment. We're preemptively thinking through how we could address issues ahead of time. Thank you all for your attention. And if there are any comments, questions, hopefully not rude remarks, but I'll also take rude remarks. Again, thank you so much for listening to me talk, and I'll let Maria take over and handle the Q&A and discussion, however the typical webinar goes. Thank you all.
Great. Thank you, Thomas. That was so interesting. And please feel free to put any questions in the chat and we'll go through them as we're waiting for questions to come in. I wondered about the 15-mile radius. Is that because that's typical within the plant? There was a hospital within that 15 miles, or um, why the 15 miles, I guess?
Yeah, so the 15 miles was previous research published using the 15 miles. So we just stole their metric. Like I said, when I was going through, we didn't present the robustness checks. We checked 5, we checked
Mm.
10, we checked 20, 25, and the results were fairly consistent in terms of the percentages. So we just stuck with what the literature was saying was the distance. That's what we presented in the paper, but didn't seem to matter. It seemed like the pattern was pretty consistent.
Okay, that's interesting. Okay, we're still waiting for some questions in the chat. So I have one. It feels like your paper, what you guys found, is consistent with some of the things we were hearing about, or we hear about rural communities being more vulnerable to, because of the lack of hospitals, lack of access to emergency services, things like that. It feels like what you did kind of confirm that there is more vulnerability period. But then when you have an emergency, it's just going to get much worse.
Yeah, I think that's a good summary of our results. And I mentioned it, but I didn't necessarily talk through the overall like empirical strategy that we did. So we used meatpacking as a way to motivate this. And then when we were doing the event study pictures, we moved more broadly to rural in South Dakota and Minnesota. So it was no longer just us analyzing rural meatpacking communities. It was rural communities in general. And what we found was that even rural communities without a large meatpacking plant experienced the pandemic in a similar way to how a rural community with a meatpacking plant did. A little less pronounced, but it was the same type of thing. So once the pandemic became endemic in the community, the pandemic exposed the rural community lack of health infrastructure, regardless of why the pandemic came in. So I think that's what the paper really illustrates is that the rural communities, because of the consolidation, because of the hospital closures, because of the specialists being 50 miles away, are uniquely vulnerable to especially outbreaks like the pandemic, but that also does not diminish the impact that they have to deal with on a day-to-day basis where if I'm sick with cancer and the closest cancer specialist is 100 miles away in the closest metropolitan area in my community, then I still have to spend the time commuting in. So I think broadly this paper illustrates that our rural communities are in a very different healthcare infrastructure position than more metro communities.
Yeah. Okay. If you're gonna have if you want to ask a question in the and put a question in the chat. Sorry, I can't talk now. You have a couple of minutes to do so. Otherwise, I'll just keep asking questions. Thomas, here we go. Thank you for the research. The presentation was excellent. I'm looking forward to sharing the recording and who focus on health initiatives in rural Delaware. So you've got a nice comment in the
I'll take that. Also,
comment.
one of the people in the room right now is one of my grad students, so he's probably too shy to put me on the hot seats in front of fancy people. So thank you, Andy. I appreciate you.
Well, thank you, everyone. We're down to our last minute. I know that the Thomas, you might be. Would you be willing to share your slides, maybe
Yeah.
with the webinar? And I know the paper is published, so you guys can go back to the paper. But thank you. This was so interesting and definitely gives us a lot to think about and continue to think about as policymakers. Think about healthcare and healthcare access in rural communities. So right on point for some of the discussions that are going on right now, in real life, as they say.
Well, thank you all. I appreciate the opportunity to present, and you guys have a great weekend. Stay warm.
Thanks. Bye, everybody.